from the clinical point of view, the diseases are a little bit different. We have on one side P. vera and ET, which are characterized by the tendency to develop thrombosis, while patients with primary myelofibrosis also have a certain tendency to thrombosis, but they develop more anemia, splenomegaly, and constitutional symptoms.
MF, P. vera, and ET have quite considerably overlapping manifestations, so they can all have a degree of myelofibrosis. They can all have increased white cell count, increased platelet count. The only thing that's specific is the elevated hemoglobin, which defines polycythemia vera. So if you have an elevated hemoglobin and you have myeloproliferative features, then essentially you have P. vera by definition. But otherwise, there is myelofibrosis, I guess, is defined by the extent of fibrosis. And I guess because ET and P. vera can both transform to myelofibrosis, there's a continuum, so that it makes the study of these diseases very complicated.
Generally speaking, I think that there are two different ways a patient is suspected to have an MPN. The first is just by chance. He makes a routine blood cell count and he finds, for example, an increase in platelet count. The second, unfortunately, is because of a complication of the disorders, and the commonest way is to have thrombosis. And so the occurrence of this event leads to another series of tests that finally can produce the diagnosis of MPN. When I have the suspicion of an MPN, the first thing is, of course, to speak with the patients and ask for a number of symptoms, how he feels, and if he thinks something has changed in his own life in the last 6 months, just to say. The second is, of course, to have a complete blood cell count and other general exams for evaluating liver function and so on. I need a careful objective examination, especially to find if the patient has splenomegaly or hepatomegaly or other manifestations. Finally, it is very important to have a bone marrow examination because the histopathology is fundamental for making diagnosis according to the classification of the WHO in 2008. And this is very important to distinguish among different MPNs because the presence of the JAK2 mutation just says to us that the patient has probably, very likely, an MPN, but does say nothing about the type of MPN. If I really suspect that there is an MPN, it is now mandatory, I think, to have a genetic analysis for determining if the patient has a mutation in JAK2, particularly the JAK2 V617F mutation.